Hello, hi, Dr. Francis Cyran. We're talking about knee pain and how some of it can be treated non-operatively, and trying to define when it does and when it doesn't, and solutions for that. A bit of background about myself. I'm an orthopedic surgeon, board certified at Mercer-Bucks Orthopaedics. I've been here for about 6-7 months now. Prior to that, I was at UCLA, so my training was in bone tumors, soft tissue tumors, where we replaced entire bones. And I also did a lot of the complex total joints for people with short statures, redos from other places, countries, etc. I was there for 15 years, tenured professor there. I also worked at the Veterans Hospital, where I operated a lot of veterans, took care of them after combat injuries. I did my fellowship at UCLA, and I did my medical school at Rutgers, Newark. I'm a member of the Academy of Orthopedic Surgeons, Hip and Knee Society, Muscular Tumor Society. So background, sources of knee pain, we often define it coming from two essential places. One, from within the knee, and two, from outside the knee. So sometimes the knee hurts, but what's causing the pain is not from the knee itself, it's from a spot outside. It's not unlike when people have a heart attack and they have pain in their arm or their shoulder. So nothing's wrong with their shoulder, the pain source is from somewhere else. So what is your knee? Knee is it's a complex joint. It's made out of a couple of different joints, actually. So there is the joint or interface between the two bones of the femur or thigh bone and your tibia or shin bone. And then also it's the joint between your kneecap or patella and the femur. And then we have some pictures there, a sideways view and then another one. And there's a lot of other structures within the knee as well. We have some tendons in the front that control the muscles that lift your leg up. We have some ligaments on the side that keep the bones in place, as well as some ligaments in the front that help stabilize it. Just some more anatomy pictures besides the cartilage covering, which is the white covering end of the bone. If you've had a piece of chicken, you know what the ends of the bone look like white. That's the cartilage. Inside the knee, there are also the ligaments that we talked about, as well as some different little cushions called the meniscus, etc. So there's a lot of different structures in and around the knee, muscle attachments that all can cause pain. And depending on where the source of it is, different options are available. So just a quick list of structures within the knee. We have the bones, we have the femur, tibia, patella, we have the cartilage, that's the covering of the bone. Again, we have our two meniscuses. Those are little C-shaped cushions, one on both sides, in between the thigh bone and shin bone. We have our four ligaments. We have two in the middle that crisscross, and then two on the side. They keep the thigh and the leg bone, or the shin bone, in place from moving around. We have the synovium. That's the lining that holds all the fluid in. We have the synovial fluid. So that's the water inside the knee. It's normal. It's kind of like oil in a car engine. And that helps lubricate the bones. And we also have what's called the capsule or the pouch, and that's kind of a thick fibrous covering that helps also support the knee. And we also have something called a bursa. It's a little cushion inside the knee that helps kind of protect the bones and muscles from the outside environment. All these things can be sources of pain. And the question is, what's causing the pain, and then we know how to treat it. A lot of people are probably wondering about knee replacements. We typically do knee replacements for cartilage coverings of the bone or certain breaks on the ends of the bone. All those other structures, we generally don't do knee replacements for. So we're mostly doing knee replacements for arthritis. So there's a lot of other things that can cause pain in the knee, you know, that do not need surgery, that could be treated conservatively, etc. So again, where's the pain coming from? So when we talk about extrinsic or outside sources of pain, sometimes the knee will hurt, but there'll be nothing wrong with it. Areas that commonly cause pain in the knee are typically the muscles that are running down to the knee, sometimes the hip joint itself. When people have arthritis, can sometimes present or show up as pain at the top portion of the knee. And then the back. When you hurt your back or pinch a nerve in your back, sometimes that can cause pain in the knee, the leg, the foot, the ankle, and other places. So as an example from the hip, we have a lot of different muscles listed. And depending upon where they attach in the knee, it can cause pain in and around the knee. And this is why physical exam by your physician, where we have to kind of poke and prod and see what hurts, unfortunately, to make you hurt. And that tells us what's hurting. And then once we know what's hurting, we know how to treat it. So there's a lot of different muscles that run in and around the knee, including your hamstrings that run around to the front. And these also can cause knee pain itself. In addition to that, hip arthritis also can. Here's an example of hip arthritis in a patient. So we look on the right side, we can see a very arthritic joint. There's no space left in between the bones as compared to the other side. And it's fairly common that people sometimes don't have hip pain or very little, but they'll have knee pain. And they say, you know, doc, my knee hurts, we'll take an X-ray, we don't see anything. But if we examine the patient's hip, we'll find that it's very stiff. We'll take an X-ray, we'll see that they have bad arthritis. Sometimes it's difficult to convince patients that this is causing their knee pain, and we can sometimes administer an injection if it's not too bad. And other times you wind up doing the hip replacement surgery, which takes care of the knee pain. So sometimes it's not necessarily intuitive what's causing the knee pain. Back. It's very common that people have herniated discs, pinched nerves in the back, sciatica, that nerve will travel from the back, and we can see a little picture here on the back. There's a lot of nerves there going to different parts of the leg, and that sometimes they will have pain. So sometimes your back doesn't even hurt if you have a pinched nerve, but it can present as pain showing up elsewhere. So again, that's why physical exam is important. And sometimes your knee may hurt, but there's nothing wrong with the knee, and the pain is coming from outside the knee. So again, that's something to find out. Now we talk about intrinsic pain, or pain that's actually from within the knee. And that was that list of all those structures that we had mentioned before. So of the bones, we have the 3 bones listed: your femur, your tibia, your patella, your thigh bone, your shin bone, your kneecap. People can get bone bruises from a fall, non-displaced fractures, or little tiny breaks where the bones haven't shifted very much. They can also get something called AVN, or avascular necrosis, where the bone dies from a host of causes. Sometimes steroids, alcoholism, and other factors can cause the bone to die and the bone to be very painful. Often these can be treated conservatively, meaning just limit the weight on it, giving some pain medication, and sometimes they can get better. We talk about the cartilage. So the cartilage, again, is the covering over the bones. If we look on the right, these are some pictures from within the knee. The top left corner is what normal cartilage looks like. It looks like the end of a chicken bone, nice and white, and shiny and smooth. When we start to develop arthritis or wear through the cartilage, we'll start seeing a big empty spot where the cartilage is rubbed through. And we can tell that on X-ray. If we look at a normal X-ray, we'll see some space in between the 2 bones. Since the cartilage is mostly water, it'll show up as a space holding the bones apart, but we know if we wear the cartilage away, the bones will touch. And if you look at that picture on the right, we can see the bones are touching. We know we have bad arthritis in that knee, and we'll probably need a knee replacement at some point. So it doesn't look too bad. That's generally good in your favor, and you probably will not need a knee replacement. There are different types of arthritis. The most commonly type of encountered arthritis is something called osteoarthritis. That's wear and tear arthritis. There's the rheumatoid arthritis, which is an autoimmune condition. If we look at these pictures down on the bottom, the black is the normal joint fluid, but the middle picture is missing the white cartilage. And then that's wear and tear issue. If we have rheumatoid arthritis on the right picture, the whole knee is inflamed and irritated, and so everything is affected, including the lining and the covering of the knee, which we really can't address with a knee replacement. I'll get into the treatment of that later. So cartilage covering of the bone, what to do about it? You know, there are different amounts of wear and tear. Sometimes there's just some roughening of the cartilage, and sometimes it's completely gone. So when it's just roughened, or even completely gone, there are various conservative things that we can do to treat it. The main issue for wear and tear with the knee is weight, excess weight by far. The knees see about 5 to 10 times body weight. So, you know, if you're 50 pounds overweight, that means your knees are seeing 250 to 500 pounds extra force across your knee, and that's responsible for the extra wear. It's also responsible for a lot of the pain. The weight loss is is the best bang for your buck in terms of reducing the pain, reducing the wear and tear. It's difficult though, however. Ways that we can treat the knee though are with different types of injection. So we can either inject a cortisone shot into the knee. You can get those about every 3 or 4 months, spaced apart without any significant side effects. And that'll reduce the inflammation, the swelling, that'll allow you to exercise and help reduce the pain. And there are these other types of injections called gel injections, or you may hear about them as rooster comb injections. That's basically a compound from within your knee that's normally found there, that's been concentrated, and basically we inject it and it coats the bones and lets them glide past each other smoothly. That works quite well. In addition to mild arthritis, we also have what are called NSAIDs, or non-steroidal anti-inflammatory drugs, Motrin, etc. You hear about these, and there are a bunch of prescription ones. These are non-addicting. These are safe to drive with. They're compatible with most medications, etc. Other things that you can do to help with any arthritic joint is some sort of non-impact exercise, walking, cycling, bicycling, etc. Basically, exercise 5 days a week has been shown to have significant benefits in reduction of pain, and increase in activities as opposed to even just 3 days a week. So that's something that you need to do. Rheumatoid arthritis, again, that's often treated with various injections and pills by a rheumatologist, and that reduces the inflammation of the joint itself. There are some other treatments besides the things that I mentioned. There are a lot of supplements. You may have heard of glucosamine chondroitin sulfate. Initial studies thought they may have been benefit, but long-term studies, very effectively designed studies, showed that they were no more effective at reducing pain or reducing wear and tear than just simple sugar pills. So they really don't seem to have any significant benefit, all these drugs and supplements that you hear about. You may have heard about stem cell injections. These are often very expensive. I've seen them listed anywhere from $4,000 up to $10,000 or $15,000. Unfortunately, they've only been shown to be effective against mild arthritis of the knee. The effectiveness is about as effective as a $30 cortisone shot. It tends to last as long. So I tell most of my patients to save my money, or save their money, and just get a cortisone shot instead. It's just effective and saves them money. There are different growth factors that you can inject into your knee. You may hear about platelet factors, etc. Really haven't been shown to have any significant long-term effects in terms of preventing arthritis. They may be slightly beneficial at healing some acute injuries, but the studies aren't really super clear on that as well. The meniscus we've talked about before. Again, those are two little cushions in between your thigh bone and your shin bone. They will often develop some fraying or degenerative wear and tears, kind of like a pair of jeans that you wear that are a little bit too long and drag, and they get a little roughened on the edge. And that can be painful in the knee. It can induce a lot of swelling. Typically with normal physical therapy and exercise, you'll kind of knock off that little worn piece and it'll get back to normal. Obviously, there's always surgery available for these things if it's a bad injury. We generally do not operate on these in the face of arthritis because patients may temporarily do better, but long-term get worse, long-term need knee replacement faster. So it's very common to see meniscal damage with arthritis, and that's not something that you treat with any kind of arthroscopic or cleanup surgery. That's something that will be taken care of at the time when you need your knee replacement surgery. Ligaments, we've talked about the ligaments. These are typically what you hear referred to as damage with a sprain. These are typically treated with bracing. For minor injuries, for complete injuries, obviously you may need surgery. Again, these are fairly rare. Synovium, again, this is the joint lining that can be irritated for a variety of reasons. You could have a little bit of bleeding inside your knee from a trauma. Could be from just irritation from generalized arthritis. These are treated with medication, like we talked about the NSAIDs and steroids, and also some of the other medications available from the rheumatologists. Synovial fluid, that's again the oil, the lubrication within the knee. That can have various little crystals in it, like gout or pseudo-gout. These are treated with medications. Excess fluid sometimes can be drained from the knee if it's bloody, etc. Although typically if you have arthritis, I do not drain them because the fluid just reaccumulates in a couple days. So it may make it feel better initially for the first day or two, but the fluid accumulates quite quickly, etc. And this can be also treated, the excess fluid, with a steroid shot and or the pills, and that can help reduce the pain and tightness in the back of the knee that you feel when you have excess fluid or synovial fluid in your knee. The joint or the capsule, the last thing, this is the pouch that surrounds the entire knee, keeps the fluid in. It may give some structural support to the knee. It kind of acts like a ligament, and so you can sprain it or irritate it. And these are generally treated with just letting it rest and heal up naturally. The pouch, sometimes when you have a lot of fluid swelling in the knee, will form something called a Baker's cyst. Basically, the pouch gets like a little bubble in the back where it's weakest, and the bubble will kind of travel up or down the knee and can cause some pain back there. Often we treat this just with a steroid injection, etc. And that typically resolves when you have a knee replacement taken care of. So again, with intrinsic knee pain, cartilage damage, it's normal with age. When we're 20, the knee looks like a nice smooth surface. As we get to 40 or so, it starts looking like a cobblestone street. So you may have some rough and wear and tear in it, but you still may have an adequate amount of it. Again, this can be treated conservatively. This is a picture of what knee arthritis looks like on a regular knee, and this would be after with the knee replacement. And so all the structures aren't replaced with the knee replacement. And so we want to always try to treat a knee conservatively first before going to a knee replacement. Typically, we would try to treat a knee with conservative measures, meaning weight loss, exercise, injections, and then medicines for bad arthritis before pursuing a knee replacement. And that depends upon the patient and what their pain tolerance is, etc. So typically we're replacing a knee if you have pain that interferes with your quality of life, your activities of daily living, or your walking ability. You know, basically the question you have to answer yourself or ask yourself is, does it hurt bad enough to want to have surgery? If the answer is no, then don't have it. You never have to have a knee replacement or hip replacement. It's basically only when everything else doesn't work and you're tired and you want to get it done. So you can always put it off for many years if you want without any side effects or issues with it. We can always replace the knee at any time without any downside with you. The end function will be fine no matter what. There are different types of knee replacements, total knee replacements, partials, etc. And there are some pluses and minuses to all of these, so we'll talk about that later. For a total knee replacement, we're replacing all the surfaces. It's a bigger surgery. We typically do this for when you have arthritis in multiple spots in the knee. We divide the knee up into 3 sections: the inside of the knee, the outside of the knee, and then between the kneecap and the thigh bone. If you have arthritis in more than one section, then we'll often wind up doing what's called a total knee replacement, where we cut the bones off the ends of it and we put metal caps on both sides. So here's an example of what a total knee replacement looks like. We can see the bright metal shiny bits, the plastic lining in between the two. There are also things called partial knee replacements, where if you have arthritis only, say, on the inside or maybe just on the outside, and the rest of the knee looks pretty good, so we have an x-ray visualizing the arthritis on the inside portion here, and the outside looks fine. We can just replace that one area. There's also some arthritis between just the kneecap and the thigh bone, which is very rare, and we can replace that as well. That's just a picture of the patellofemoral arthritic joint with the replacement in it. In terms of what's a knee replacement made out of, a knee replacement's made out of a few different materials. There's generally 2 metal parts with a slippery plastic piece in between. The kneecap is often covered with a plastic covering, although not all the time. In Europe, they don't bother to put coverings on them. I'm very selective about who I put that on, so about half my patients have the kneecap covered and the other half don't. The idea is that we let it be thicker and therefore less subject to strain, which works better for patients. Knee replacements are fairly good surgery if and when you need it. Typically, we're thinking they last 15 to 20 years or so. Probably 80% of the patients still have their original knee replacement and functioning well after 20 years. So timing is always something to think about for your knee replacement. You don't want to get it while you're too young. You might need to have it redone. So the idea is to get it done once and then you're done for the rest of your life with that. There are some differences between the partial and the total knee replacements, et cetera. That's not really on the scope of this talk. I can talk to you about that at another time. Knee replacements are pretty good, but they're not perfect. They do have incomplete relief of pain. It takes patients about a year to get used to them. Still about 12% of the patients will take some pain medication despite everything functioning well. The artificial knees will always permanently look bigger and swollen compared to the rest of the knee. Many patients report that they cannot kneel on their artificial knee. It doesn't damage it, but it's very painful. And there's probably about a 80-something% satisfaction rate, meaning 20% of the patients aren't real happy with it despite the pain being better than before. So it's not a perfect surgery, and that's why we try to manage patients conservatively before going to the surgery. Why does arthritis hurt? It's loss of the protective cartilage. So when you lose the slippery cartilage covering over the bones are rubbing on themselves and it causes a lot of pain. I liken it to wearing a pair of shoes. If the sole of the shoe is intact, you can walk on gravel, it's fine, it doesn't hurt. But if you wear a hole in your shoe, sole, or the cartilage covering and you walk on gravel, you're gonna feel it hurts a lot. And so that's why arthritis tends to hurt, and that's why we try to do things to help with that. So there are some braces available for isolated arthritis that can kind of shift the weight from the good portion, or from the bad portion to the good portion. And that's why we also have these other medications that reduce the pain and swelling of the bone, and therefore that takes care of that as well. What does knee arthritis feel like? It's typically pain. Pain in the front of the knee, although sometimes some tightness in the back of the knee. It's typically pain with activity that limits your walking. Generally, arthritic joints or knees don't hurt a lot at rest. So if you're having a lot of pain at rest, it may not be from the knee, it may be a pinched nerve or something like that. Arthritic knees tend to have a loss of motion. They're very stiff, they're swollen. Many patients report that when they get up, it takes a few steps. They have to walk before loosening it up. And so that's what a commonly arthritic knee feels like. If they don't have all of these symptoms or a lot of them, it may not be arthritis, and therefore it may be something that could be treated conservatively, meaning non-operatively. So things that aren't knee arthritis, again, are pain all the time, even at rest, or it doesn't affect your walking ability. So if your knee hurts all the time, you have you can walk a long distance, like half a mile or a mile. Probably not going to be knee arthritis. There's probably going to be some sort of other pain that's in the knee area, etc. There are some different ways of doing knee replacements, robots included, which I do occasionally, but there's been no proven benefit for them. Etc. Most of the knee replacements are the same no matter how you do them. Just to give you an idea about knee replacements, right now we're doing about 1 million per year. At age 50, probably about 1% of the population has a knee replacement. By the time they're 80, probably about 10% will have a knee replacement. In terms of age, young as 40 years old, we're doing them now with the idea that they'll probably need it redone. If you're younger than that, then we really have to be very careful about that because the younger patients tend to wear them out too fast and have more issues with them. As far as age goes, we put them in as old as 95-year-old and older. Again, it depends upon the patient. There's some pretty young 95-year-olds and there's some pretty old 65-year-olds depending upon your medical conditions. Again, I think I already mentioned about osteoarthritis. Again, that's wear and tear, kind of like the tires wearing out on your car. Again, excess weight is the #1 cause of that. And you see 5 to 10 times body weight with bending. So really, weight loss is probably the best thing that you can do in terms of reducing the pain in your knee and reducing the wear and tear. Many patients report a significant difference in pain just after losing even 10 or 15 pounds. I've had a couple patients who were very heavy, probably more than 100 pounds overweight with horrible bone-on-bone arthritis. No one had talked to them about weight loss before. They went and lost the weight and they didn't even want surgery. The pain relief was so great. Trauma can also cause arthritis from a bad car accident. So sometimes, 10 or 15 years later, the knee may develop that. So it's something to keep an eye on. Also did mention again, rheumatoid arthritis, that's an autoimmune condition where the body attacks the joint lining. And that's often treated with medications and injections, but that does affect the joint. So that even though if we did a knee replacement, sometimes that can't get rid of all of the pain, that the pain may still be there in and around the joint itself because the lining of the joint is still inflamed and we can't manage or do anything with a knee replacement. So sometimes a perfect knee replacement in a rheumatoid patient may still have pain due to those outside issues. That's mostly it for the talk. I heard we may have had some sort of video problem, so we're going to end that here. I'm going to look at the questions and go through them. I'm just going to start and work my way down. I do have time for some. So Baker's cyst, I mentioned that. Baker's cyst is basically just outpouching of the lining of the joint. It's typically there after some sort of inflammatory process, meaning that the knee is irritated, producing extra fluid, and it kind of just pouches out there. We generally just treat the symptoms. We don't generally excise them or take them out with surgery. Usually the Baker's cyst resolves once you've had a knee replacement. So I do operate on them occasionally if the patients do not have arthritis and they're very symptomatic, but sometimes they can be filled up with very thick fluid that can't be drained necessarily. With a standard needle and a very large gauge needle to be put in by someone from interventional radiology. Second question. Someone said a stem cell transplant with meniscal repair, lost 50 pounds, received injections. The surgeon said you're a candidate for a partial replacement. What is the safe time to say the stem cell didn't work? The stem cells are not going to do anything to replace bony deformation. We really haven't seen them grow any cartilage yet, etc. As far as safe time for any knee replacement, after anyone sticks anything in the knee, we generally want to wait about 3 months, be it an injection or taking fluid out, etc. So anytime after 3 months after the last shot would be fine to have surgery. There are no braces that can benefit Baker's cyst. You can wear certain braces called unloader braces where if you have some arthritis on the inside or the outside of the knee, that may shift the balance from one side to the other. It may make the knee less symptomatic, but generally braces do not treat Baker's cysts. She has an arthritic right knee and replaced left knee 2 years ago. Will the knee become worse if I age and don't pursue any therapy or injections? Knee arthritis is progressive. It's like wearing the tires out on your car. So eventually you drive enough miles, the knee might wear out. So it's naturally going to become worse with time. So again, you can do things like we mentioned with exercise, with weight loss, and all these treatments are basically just to reduce the pain. we don't have any solutions that make the cartilage better. You know, none of the stem cells or any of these other injections make the cartilage better. All these treatments are basically trying to reduce the pain so that you can have a good quality of life and avoid surgery and do the things you need to do to go out with your family and have dinner, etc. But when it becomes troublesome, that's when we talk about a knee replacement. Someone asked about knee donors. If I'm thinking what you're asking is, there are a few surgeons who can take cadaveric bone, meaning bone from a cadaver, someone who died from something, and take healthy cartilage and screw in or bolt on with the various types of screws and other devices and replace the worn out cartilage. This isn't done very commonly done. It could be a bit tricky, but there are a few surgeons in the U.S. getting this who do this. I've done things like this for bone tumors, etc., but it's not a real common thing for arthritis. The patients have to be very carefully selected. Typically, we want to do this in a very young patient, 20s or 30s, who've had some sort of trauma, etc. So this is probably not going to apply to 99.5% of the patients out there. Do I recommend replacing both knees at the same time? There are limited reasons to do this. One is what's called a flexion contracture, where the knee does not become fully straight, because if we replace one knee and the other knee is bent, then the operated knee stays bent. There are certain risks for replacing both knees at the same time. I've done that. The risks are increased amounts of blood transfusions. Generally, I don't think I've ever transfused anyone with a total knee, but if you get both done at the same time, it's common to need a transfusion. There's a much higher chance of going to a rehab place. There's also a significantly higher chance of getting blood clots in the leg and or pulmonary embolisms where they go to the lungs. And a couple of my patients who I've done both knee replacements on at the same time have had this. So it's a very risky thing. So I would tell my mom and dad, or personally myself, to get one done, recover, and then do the second one. Sometimes it's as short as 6 weeks. So I tell my patients when the first one is done, it feels better than the other knee or hip, then it's okay to proceed with the second one. A lot of surgeons will do this because it's a time saver. It's easier for them to get both cases done. It's somewhat convenient for the patients, but there is a significant medical risk for that. I personally would not recommend that for my family. So I leave it up to you. I've been wearing a strap under my kneecap. It seems to work to reduce pain and after tennis. Why is that? There's something called the gated theory of pain, whereas that if your knee hurts, the brain can only handle so many responses at once. So if you distract it by putting pressure on it or icy hot or rubbing another area, the body only handles so many responses at once, and therefore you don't notice the pain as much. So it's likely that's what that's doing. So a lot of the braces, the wraps around the knees will tend to distract you from feeling the pain. It gives you a different sensation. That's how those things work. Someone asked, is osteoarthritis hereditary? It can be slightly inheritable, so it's not necessary that, if your mom or grandpa had arthritis, that you're going to get it. There are many more environmental factors, namely excessive weight, that are responsible for that. So there's a bunch of questions here. I'll try to answer some of them. When a knee is swollen, what to do after it happens? Using RICE, that means rest, ice, compression. Typically, injuries are treated with icing at first. For the first 2 or 3 weeks, it's effective. Afterwards, you can use heat to loosen it up. When a knee is swollen, how many days before starting sports? It really depends upon how badly the knee is hurt and what type of activity you're doing. There are people who play badminton, and then there are people who play badminton with very different levels of activity. Generally use pain as your guideline. If it's just swollen from a minor injury, as long as it doesn't hurt too bad, I'd say it's okay to go back gingerly and see if it produces pain. If it's still hurting, then you need to rest more. Exercises at home, generally any exercise, strengthening of the thigh muscles, the hamstring muscles in the back, as well as the ankle. It can help prevent injuries and help lessen the injuries. So any sort of exercise is helpful. Strengthening has been shown to reduce falls and also reduce breaks after falls too in elderly patients. What to eat? Vegetarian to make knee and body stronger. Again, that's a difficult question to answer. Just generally a good diet is helpful, and to avoid fads or extremes. As far as eating before or after sports, there's no benefits to one or the other, etc. I was diagnosed with mild distal quadriceps. That means at the end, down by the knee, and patella tendinosis. What are the thoughts of getting the PRP shots? These have been shown to be mildly helpful for some patients in helping these heal. I don't do a lot of this, so I usually refer patients who want that kind of stuff done to our physical therapy doctors, and these are the non-operative doctors who spend more time on that. Can doctors quantify and assess physical strength discrepancies? We generally do this physically in the office, so we can look for gross differences. There are specific Cybex machines that can actually measure, 50 versus 58 pounds of force, etc., and try to strengthen that if appropriate. And what to do about runner's knee if PT doesn't work. Again, it really depends upon your problem. I can't answer necessarily specific questions like that because it really depends upon what's going on with your knee and what's been tried already. So your best bet is to come in and see one of our physical therapy physiatrist doctors who specialize in sports injuries, and they can go through the step-by-step list of things that could be done, and we really need to find out what's wrong with your knee at first, okay? Can lowering salt in food help with knee inflammation? Probably not. It's not going to help with that. I know there's a lot of talk about various foods that are high in anti-inflammatories, like blueberries and things like that. They do have some very mild effects in terms of preventing inflammation, etc. Most of the medications that we use are derived from plant products that we find and that we've improved. So the efficacy, how well it works with the medications are usually, 1,000, 10 times 1,000 more effective at preventing inflammation than, say, dietary foods are. So, people eat blueberries or there are some other spices that people say have anti-inflammatory properties, and they do, just like willow bark does, but they're not nearly as strong as the medications. So you're welcome to try it. There's generally no harm in it, but it's probably not going to be terribly effective. Can knee replacement cause back pain in some people? It's a very common thing after any sort of leg surgery to have back pain afterwards, just because you tend to limp in the recovery phase. So when you limp, you kind of waddle back and forth, you cause more stress on your back. So I tell most of my patients that, if you have pre-existing back pain, it's going to be higher right after the surgery. However, the good news is that probably in about 2/3 of patients with pre-existing back conditions, they will experience an overall decrease in their lower back symptoms once they've recovered, because they tend to be walking better and more smoothly. So it's fairly common to see an increase initially, and then later on a decrease and often improvement.
Hi, Dr. Cyran. I'm going to hop in real quick because I do know you need to get back to your afternoon hours. I just wanted to thank you for taking the time to educate us on non-operative knee pain, as well as some of the options available for knee replacements. I do want to thank everyone. And if you do have questions that weren't answered today, I apologize. I just want to make sure he gets back to the patients he needs to see this afternoon. But you can always reach me at programs@mbortho.com. That email is on the screen, and I'd be happy to answer your questions once I consult with Dr. Cyran on them. If you would like to schedule an appointment with Dr. Cyran, please call the number on the screen at 855-896-0444, or we do have an appointment request button on our website at www.mbortho.com as well. So we thank everyone for coming out. We hope you enjoyed the lecture, and we look forward to seeing you next time. Thanks so much.
Bye.